Welcome to AETCM, the emergency medicine channel. Today let us discuss about one of the important rheumatological condition, that is systemic lupus erythematosus. So one of the important connective tissue disorder. Most of these patients are women. That is very important. This finding is very important, and they are mainly in childbearing age group. So young women is the classical patient who can have SLE, but male SLE is also not very uncommon, but we can get some patients with male SLE. But these male SLE patients will be very severely affected. That is a major problem. So these patients can have periods of remission and chronic and acute exacerbation. That is one of the another important feature. For many years, the patient will have an acute problem, then it will come down. For many years, it will be static. On treatment, it will be static. Suddenly, patient have relapses like this. So that can have acute on chronic SLE. So most of these patients, since it is an inflammatory disorder, most of these patients can have chronic fever. Chronic fever will be one of the important finding in many patients. Even if the patients on remission, they can have myalgia, fatigue, all these things. So these are the typical findings in most of the patients, and very rarely this disease affects the male person. So the ratio will be somewhere around men to female will be uh, 9:1. 9 female, 1 male. That is a ratio. So this is a classical example for chronic inflammatory disorder or immune mediated disorder, autoimmune disorder. So this is very common in female patients. Like any other immune mediated disorder, very common in female patients. Now this picture will tell you the various clinical findings of SLE. So we will see other findings also. So they can have malar rash. That is the most important clinical feature. Malar rash is the most important clinical feature of SLE. So butterfly or malar rash, red rashes over the face, that is very important. Then you can get some discoid rash over the skin. There is another feature, and various areas you can get multiple palpable purpuric rashes. So basically SLE is a skin disorder, systemic lupus erythematosus. Redness of the skin is the classical finding. But what happens is these disorder even involve other areas of body, like almost all organs in our body can be involved by SLE. It is something like tuberculosis. Tuberculosis is a chronic inflammatory disorder, but it is due to an infection. This is also chronic inflammatory disorder, immune mediated chronic inflammatory disorder, but it is not due to infection. But if you see the findings, you can see many patients can have fever. Because of this chronic illness, many will have depression, fatigue, weight loss and all. So that will be the general finding. And if you see the eyes, 15% of the patient can have dryness of eyes, that is called as Jorgen syndrome. But the major chunk of the patient can have skin disorder. So that is a classical finding you see in SLE. Photosensitivity, butterfly rash over the face, vasculitic disorder, that is purpuric rash all over the body, urticaria, all these things. Then patient can also have chest disorder. Like almost all areas in your body can be involved in SLE, but there's some peculiar finding can be there. Like polycirrhosis is one important thing. Like patient can have pericardial effusion, patient can have pleural effusion, patient can have ascites. So all these things all together called as polycirrhosis. So pleurisy, pleural effusion, then ILD, interstitial lung disease, that is restrictive lung disease, another problem. So these are the important findings. Then if you see the major clinical finding will be joint disorders. So joint disorder means many of these patients can have joint disorder, joint inflammation, but they are not deforming joint inflammation. Whereas you take rheumatoid arthritis, that's a deforming type of joint disorder. This is not a deforming type of joint disorder. Another important area where involvement will be there in the brain. So these patients can have seizures, weakness, that is hemiplegia or paraplegia, ataxia, that is cerebellar disorder, cranial nerve disorder, psychosis. All these things are very common. Then heart also can be involved. All layers of heart will be involved. Myocarditis, pericarditis, endocarditis, all these things are possible. Then abdominal pain, peritonitis, vascular lesions in the abdomen can be there. Renal disorder is another important finding in many SLE patients, that is lupus kidney, that we will see afterwards. Many patients can have inflammatory myositis. Then blood, one of the major finding will be blood disorder. Patient can have anemia, leukopenia, lymphopenia, thrombocytopenia. In that, lymphopenia is very classical in many patients, and thrombocytopenia is also seen in many patients. Ultimately, all the three cell lineages can be reduced. Patient can have severe anemia, infections, bleeding tendencies. All these things are very common. Sometimes liver also will be involved, so hepatitis can be there. A lot of findings can be there. So almost all organs in our body can be involved due to SLE. But if you take the skin, one of the classical finding will be, like you can see the multiple rashes all over the body. It can be even on the face, that is butterfly rash. And alopecia is one of the major finding in SLE. You can see hair loss. Hair loss can be there even on head, face or axilla, wherever it is, alopecia can be there. Dryness of the eyes, that is another important problem. Rashes are there. Then oral mucosal ulcers, that is very classical in SLE, oral mucosal ulcers. Some patients can have Reynolds phenomenon, that is due to vascular collapse. So you see that there is a obstructive lesion, there is a spasm of the blood vessel that reduces the blood flow to the fingers. It will become white, then it will become blue because of cyanosis. Then once you warm the area, it will become red. This is called as Reynolds phenomenon. Now there are some criteria, diagnostic criteria. If you have more than 4 or more criteria are fulfilled, then you can make a diagnosis of SLE. The sensitivity is around, specificity is around 95% for this criteria. Sensitivity is around 75% of this criteria. But if you are getting only 1 or 2 conditions like this can be even told as minimal SLE. But the one of the major feature of SLE will be malar rash. Malar rash means on the face, you can see the face, both sides there will be redness, and it will be like a butterfly. Okay, so butterfly rashes are classical for SLE. So that is very important. Then discoid rashes you can see on the body. It's the same type of rashes if you are seeing in circular rashes, if you are seeing on the body, then you can call it as discoid rash. Then photosensitivity, exposure to sunlight, many patients can have rashes. There is another important thing. Oral ulcers are very classical in SLE. Painless oral nasopharyngeal ulcerations are very common, and it is mostly painless. Arthritis, non-deforming or non-erosive arthritis is very classical, whereas rheumatoid arthritis, it is erosive and deforming. Serositis, polyserositis like pericardial effusion, pleuritis, uh, pleural effusion, and peritonitis. All these things are very common. Renal disorders are very important. Lupus nephritis. Initially, you can see only proteinuria. Then you can see creatinine is elevating, and patient may go to chronic renal failure. But most important finding will be proteinuria. And many patients with neurological involvement can have seizures. They come with simple seizures, and we'll have to investigate for, suppose a young lady without any other finding, she is developing seizures, look for SLE. So that is very important. Seizures are very classical. Hematological disorders are very important because all types of cells, like a patient can have anemia, that may be hemolytic anemia, leukopenia, thrombocytopenia, all these things are seen in this type of patients. SLE. Lymphopenia is another classical finding you get in SLE. Immunological markers, main thing what we do in our practice is anti-dsDNA. Other markers we'll see afterwards. Anti-dsDNA is very important. Then ANA also we do, but ANA problem is ANA can be positive in many other conditions, including in a normal person also you can get. But if you see the titers, like if the titers are very high, then you have to suspect SLE with clinical findings. Now this is the butterfly rash. What you are seeing here, it is like a butterfly. So this is the typical butterfly rash in SLE, but in an Indian population this may not be very visible because of the skin color, but whatever it is, it's a photosensitive rash, or most of the time it is on the face, it is on sunlight exposed area. 80% of the patients, nearly 84% of the patients can have this, but in Indian population you may not see this much colored rash because of our skin color is slightly darker, and most of the time this is sensitive to sunlight. And this type of rashes you can see everywhere in the body. You can see even the trunk, abdomen, lower limbs, but they are like small rashes, not like a typical butterfly like this. Now these rashes are called as discoid rashes. They are like a disc shaped rashes, especially on the upper chest of the body. Again, this type of rash is also not very common in our population. You can see it, but fair skin patients, you can see it. They are discoid rashes. Okay. So basically, SLE is a skin disorder. It's an immune mediated skin disorder or hair loss disorder. But unfortunately, this also immune mediated destruction can also involve other organs in our body, like heart can be involved, brain can be involved, eyes can be involved, liver can be involved, kidneys can be involved, nerves can be involved. So almost all organs in our body can be involved in SLE. It is something like tuberculosis. Tuberculosis is a granulomatous disorder caused by a bacteria. Here it is caused by immune mediated destruction or altered immunity in our body, which produces this problem. In kidney, it mainly produces glomerular nephritis that produces proteinuria. Proteinuria is a classical finding you get in lupus kidney. WHO has given us a grading for that. Grade 1 is no histological changes. Grade 2 mesangial proliferation. Grade 2 focal proliferative glomerulonephritis. Grade 4 is diffuse proliferative glomerulonephritis. Grade 5 is diffuse membranous changes. Grade 6 is end stage renal disease. So whatever it is, initially it will be only proteinuria. Then slowly progression, you can see creatinine can be elevated. Then slowly progress to CRF. But if you treat at this stage itself, it can arrest the disorder and you can reduce the disorder. So it's an immune mediated kidney destruction. So you have to always, whenever you get an SLE patient, you have to always look for proteinuria. So 24-hour protein estimation should be done. We have to document it. We have to see whether that is increasing or decreasing or static. Now, lungs in SLE, it is many patients with SLE, you can see actually they are developing pleural effusion, pleuritis. Sometimes you can see interstitial lung disease. Interstitial lung disease means in the interstitial space, normally you get normal lung parenchyma, but that will be replaced by fibrotic tissue. What happens is, because of this fibrotic tissue, the oxygen, carbon dioxide, that diffusion part will not occur properly. So patient develops hypoxemia. On auscultation of lungs, you get bilateral crepitation. It is called as Velcro crepitation. So ILD is one of the most important complication of SLD, but you can get pleural effusion, pleuritis, and many patients with SLE can have consolidation or pneumonia. Sometimes these pneumonias are due to a bacterial infection because their immunity is generally low. Sometimes the pneumonic consolidation is due to the SLE itself. So SLE itself can produce consolidation, that is because of autoimmune or immune mediated lung destruction. But sometimes patients, because of the low immunity or they are on steroids or immunomodulators, they can develop even infections. Now, if you take ANA positivity, many patients on our clinical clinical practice, you can see ANA will be positive. So all ANA positives are not SLE. That is very important. ANA can be positive even in normal population. So you should remember that unless until you have a clinical suspicion, you should not correlate that with ANA positivity, because ANA can be positive simply in normal population also, and there are a lot of other diseases which can produce ANA positivity. But whatever it is, It is very classical for SLE. It will be positive in 98% of SLE. It will be more than 95% in drug-related SLE. Systemic sclerosis or scleroderma, it will be more than 85%. Sjogren syndrome, 80%. And polymyositis, dermatomyositis, 40%. Mixed connective tissue disorder, that is SLE, rheumatoid arthritis, or systemic sclerosis, that will be 100%. So, many other autoimmune hepatitis also you can get 100% ANA positive. So ANA positivity doesn't mean that this patient is having SL. Even diabetes mellitus also you can get 25% of ANA positivity. So never think that ANA positivity means that is SLE. It only tells you that he has got some problem with his immunity, and many immune mediated disorders uh, can have this ANA positivity. Even a normal person also can have ANA positivity. So when we are treating SLE patient, we should understand that that's an immune mediated disorder. They should have symptoms with ANA positivity, symptoms that indicating a disease like SLE, and ANA positivity means that we can correlate with that. Now, we have already seen that there are a lot of antibodies which can be positive in SLE. One, we have already discussed that ANA 98% can be positive in SLE, and it can even seen in other diseases. Anti-dsDNA is another important antibody which is positive in 80%. It is double-stranded DNA. It is specific for SLE, so it may not be positive in many other diseases. But it is the high levels of anti-dsDNA always tell you that the disease activity is very, very high, and it is very classically seen in nephritis and vasculitis. The dsDNA positivity means there will be high possibility for renal involvement and vasculitis. Anti-Smith or anti-SM antibodies can be positive in many patients, specific for SLE. So that many other like rare so it can be specific for SLE, and most patients with the anti-RNP patients with anti-SM were more likely to have renal diseases. So it may go towards positivity may indicates renal disorder. Anti-RNP or U1-RNP, it's not specific. It is mainly seen in multisystem disorder, like patient can have other connective tissue disorders, SLE, mixed connective tissue disorders, and scleroderma. Antihistones, again, it is very classical for drug-induced SLE. So drug-induced SLE, think about antihistones. And another investigation is anti-RO and anti-LASSB. So they are mainly used for Zika syndrome and cutaneous lupus. Neonatal lupus is another important thing. So patients who are pregnant, SLE patients who are pregnant, and if they have anti-RO and anti-LA, then you have to investigate properly for the child, because child can have cardiac disorders like congenital heart block. So a neonatal specialist should be referred to find out all these problems. Cardiolipin antibodies and lupus anticoagulant, that patients can have thromboembolism. So in suspected thromboembolism, you can ask for anticardiolipin and lupus anticoagulant. And if an SLE patient is having this antibody, means we'll have to go for some prophylaxis against preventing the thromboembolic phenomenon. Now, whenever we treat any disorder, so we have to always think that this patient can come to OPD or this patient can come to an emergency medicine department. When the patient coming for OPD, most of the time that is due to the skin disorder. Either they are losing their like skin color, red rashes, or hair loss, something like that. That may be the complaint. So in that type of patients, mostly topical steroids can be applied, sunscreen ointment can be applied, hydroxychloroquine sulfate ointment can be applied, or hydroxychloroquine tablet can be given. Okay, so that will be the basic treatment for minimal disease. If the patient is having arthritis, that should be treated like rheumatoid arthritis. One of the most important drug which can treat both skin disorder and arthritis is HCQS, that is hydroxychloroquine sulfate, 200 to 400 milligram per day can be given, or methotrexate also can be given. Methotrexate 25 milligram once a week with folic acid. Always you should give methotrexate with folic acid. That is very important. If you are giving hydroxychloride, remember this patient sometimes hydroxychloroquine sulfate can have blackening of skin. So black skin or retinal pigmentation, both are very important. So sunscreen ointment should be applied to given to all patients, and periodic retinal examination is also must. And if you are giving methotrexate, remember we should give folic acid. So that is very important. Then anifrolumab is another important drug, that is interferon receptor antagonist, can be given used for the treatment of patients with moderate to severe SLE. So if there is no active disorder like a very severe actively disorder, we cannot give anifrolumab. The dose is IV 300 milligram every 4 weeks. Life-threatening disorders, you always depend on the steroids, because steroids act immediately. All these drugs like immunomodulators take some time. So methylprednisolone 1 gram, that is very important dose, 1 gram for 3 days are the classical treatment we give in acute condition. Or if the patient is not like if patient is poor, we can go for dexamethasone around 40 milligram you can give. That will be equivalent to 1000 milligram of methylprednisolone, and it is cheap also. Dexamethasone is comparing to methylprednisolone, this is a cheap drug. Now, in emergency room, if the patient come with acute exacerbation of disorder, or if the patient is having acute pneumonia due to an immune-mediated pneumonia, not due to infection. So, how do you know that it's an immune-mediated pneumonia or infectious pneumonia? So, you can either do culture, or procalcitonin will be very important test, because most of the bacterial pneumonias procalcitonin will be high. Most of the inflammatory pneumonias or viral pneumonias procalcitonin will be low. But the problem in SLE, when the immunity is very low, they can have a lot of opportunistic infections also can produce pneumonias, like PCP can come in SLE. Something like chronic HIV patients, because their immunity is very low. So we have to be very careful. This type of disorders also can be there. So normally in acute condition, we give methylprednisolone 1 gram per day into 3 days. So then once you finish that 3 days, you can go for oral prednisolone 1 to 2 milligram per kg body weight. Then slowly taper the dose. So you give very high dose, then 3 gram can be given. So 3 gram into 3 days. Then you start oral this one, and slowly taper over many days. Okay. So meanwhile, you can start some other immunomodulator like methotrexate or whatever it is. So that also will take care. So methotrexate, if you start, you don't get good response in initial days. That's why we give steroids initially. Then you continue with methotrexate or MMF, whatever it is. Now there is another drug which can be used instead of steroid, that is IV cyclophosphamide. So it can be given as a infusion of 40 to 50 milligram IV, that can be given in emergency room acutely. So that has got similar effects of methotrexate. Like patient is having diabetes, we are not able to give steroids, then you go for cyclophosphamide. That's a very important and good drug. Another important drug, that is a biological drug, so that is rituximab. You can give 375 milligram per meter square once weekly for 4 doses. So you can even select the dose according to the severity, but that is another drug. So you can either give a steroid or steroid sparing agents like IV cyclophosphamide, IV rituximab. Comparing all the drugs, steroids act very fast. This also acts fast, but the problem is this is very costly. So this is a costly drug. This has got side effects, lot of side effects. This cost is low and side effect is low. So most of the physicians use prednisolone or methylprednisolone, but in diabetic patients or already immunocompromised patients, some may not be very comfortable with methylprednisolone. In that case, if the patient can afford, you can go for rituximab. Now, Belimumab is another monoclonal antibody that also can be given for. So there are a lot of newer drugs which is coming for SLE. So this can be given. Dose is 200 milligram once weekly. Newer drugs are available that also can be given for SLE. But basically, the drug is steroid, rituximab, or cyclophosphamide. These three drugs are used by most of the physicians. Sometimes we give steroids with rituximab, then reduce the dose of steroids and add another drug which can act for longer period, because steroids cannot be continued for longer period. That has got a that these drugs have got lot of side effects, so we will not be able to continue steroid for a longer period, so we use other drugs. Now, once the patient is stabilized, you can go for drugs like azathioprine. That is a very important drug, azathioprine, 2 to 3 milligram per kg body weight, or mycophenolate mofetil, and that is a very important drug, and the side effects are very less. You can give 500 milligram TID. That is a normal dose. You can increase the dose if required. 100 milligram normal TID can be given. And in pregnant patients, avoid cyclophosphamide and MMF. You can use steroids or azathioprine. So these are the commonly used drugs in SLE. So we have discussed about SLE, one of the important immune mediated disorder. So you know that immune mediated disorder means there will be antibody formation. Because of this antibody formation, some organs in our body can be destroyed by this antibody complement mediated attack. The organ may be destroyed. So to control this, sometimes we'll have to give steroids or steroid sparing agents like cyclophosphamide or rituximab. Then long-term therapy is required in most of the patients. We can go for MMF or azathioprine, or even steroid can be continued. When we are continuing this type of drugs, we should remember one thing. When we are starting this type of drugs, generally they reduce the immunity of the person. So these patients are prone to develop any sort of infection, including opportunistic infections. So we have to be very careful when the patient come back with an infection. We have to always rule out whether it's an infectious exacerbation or an inflammatory exacerbation. Thank you.